Dr. Joel Vega-Rodriguez, Dr. Giselle Viana, Dr. Grinsztejn, Dr. Vangeler Gonçalves dos Santos. We invite her to be part of our initial remarks at the symposium. Dr. Luiz Augusto Galvão, Dr. Lívia Caricio Martins, also a guest. Also Gilmar Pereira da Silva, so that we can have the opening lines of the symposium. Dr. Leonardo Carvalho.
Edition of the symposium took place 2 years ago in Rio de Janeiro. This event was conceived as a mechanism to bring together scientists from Fiocruz and NIAID and discuss the latest developments in the field of infectious disease, and more importantly, to strengthen and further promote the cooperation between the two institutions. More broadly, the meeting is also intended to foster cooperation between Brazilian and American research institutions. As in the first opportunity, this edition of the symposium is associated with the Brazilian meeting on malaria research. But the choice for Belem to host the second edition goes beyond the symbiosis between the two meetings. Belem is the gateway to Amazonia and will host the COP3 event in 2025. Therefore, it was the perfect place to debate how change in environmental conditions affect the spread of infectious diseases. This subject has been particularly in the spotlight in Brazil in the past years. In the current year, Brazil had the largest number of fires in Amazonia in the country of the past 14 years. And meanwhile, we faced the emergence of the oropouch fever outbreak and went through the biggest epidemics of dengue in our history. So we do hope that the presentations and discussions that will be brought here in this meeting by high-level scientists will shed light on the current situation and on the potential solutions to fight some of the major health threats of our time. In this symposium, we will have examples of solutions that are in advanced stages for implementation, and we expect that this venue can be a great opportunity to debate them, as well as several health problems that affect Brazil, the US, and the world. Also, we expect that the new cooperations and hopefully new agreements and programs will arise from this gathering. A smart scientific cooperation between Brazil and the US can lead to synergistic rather than just additive mutual gains and benefits. I'd like to thank very much all the attendees of the symposium, with special thanks to all the speakers and moderators that have found a space in their very busy schedules to join us in this beautiful and historic Amazonian metropolis. My very special thanks to Dr. Marrazzo. Her predecessor, Dr. Anthony Fauci, had a special consideration for the relationships of NIAID with Fiocruz, and he also participated in the first symposium in Rio. Your presence here in Belem, all the way from Bethesda, is of the highest significance and clearly demonstrate your commitment to advance Brazil-US cooperation. I'd like to thank very much my friends, Hans Ackerman and Joel Vega-Rodriguez. We worked together for over a year to bring us all together here today. It has been a real pleasure and fun working with you. Many thanks also to Giselle Viana. Giselle is a local organizer and provided all the support and the guidance to get things done here in Belem. And in this regard, I think very much also Vera Bittencourt from ML Events, whose partnership has been critical in the event preparation since our first joint work in Rio Symposium. And last but not least, my thanks to the ones that provided financial support and allowed this event to take place. The Vice Presidents of Production and Innovation in Health, and the Vice Presidents of Research in Biological Collections of Fiocruz, and the Office of Global Research of NIAID. In particular, I'd like to express my thanks to the Fiocruz Vice President, Marco Krieger, who has always been an enthusiast of the Fiocruz and NIAID cooperation, and who promptly agreed to financially support this event. And also to Ms. Lucy Ruderman, Regional Officer for the Americas of the NIAID Office of Global Research, who facilitated and has always been supportive of the symposium organization. Thank you very much.
Good morning, and thank you, Leonardo. My name is Hans Ackerman. I'm from NIAID in Maryland. And as I welcome you to this second Fiocruz NIAID Symposium, I would like to raise two questions that might be on your mind. The first one is, why are we here? Here in Belem, the regional capital of Pará. As an Amazonian metropolis, Belem is uniquely witnessing the effects of climate change and its impacts on human health. Meeting in Belem also provides a sense of urgency and immediacy to the scientific presentations that elsewhere might be considered purely academic research. Meeting in Belem also provides a sense of anticipation in advance of the COP30 summit to be held here exactly 1 year from now. Meeting in Belem also gives us an opportunity to continue engaging with each other at the 17th biannual Brazilian malaria meeting, which begins on Wednesday. My second question is, why are we here? What do we expect to gain from this interdisciplinary meeting of epidemiologists, vector biologists, clinicians, data scientists, and so on? We are here because we are acutely aware that global warming has changed the dynamics of human disease risk. We are here looking for ideas, looking for ways to use our research skills to better understand, address, or adapt to the ongoing climate crisis. I hope that at the conclusion of this Fiocruz NIAID Symposium, you will have a greater understanding of how two institutions, originally founded to address infectious diseases encountered by human populations expanding into new geographic areas, are now working to understand and address changing disease patterns caused by human disruption of that geography. I hope that you can take from this symposium a sense of how your work can contribute to solving challenges presented by the climate crisis, and also new connections to people who can strengthen your efforts. Thank you. Next, I'd like to welcome our co-organizer, Joel Vega-Rodriguez, to share more details about the program we have in store for you.
Bom dia. That's about how much I'm going to say in Portuguese today. Thank you, Leonardo and Hans, for the introductions. And my name is Joel Vega-Rodriguez. I am also part of NIAID. And it is an honor to welcome you to this international symposium in beautiful Belem. I am thrilled to be organizing this event alongside my esteemed colleagues, Leonardo, Hans, and Giselle. We have gathered an outstanding lineup of speakers from both Brazil and the United States who will share their insights on a diverse range of topics related to infectious diseases and the impact of climate change on their spread. Our sessions will cover important topics, including the effect of geographic physical disruption on disease transmission and health, vector-borne diseases and the ecology of vectors, an extremely important topic here in Brazil, which is intimately related to geographic disruption. We will not only learn about vector ecology here in Brazil, but also field work done in other continents, including Africa and Asia, to understand the transmission dynamics of vector-borne diseases. We will have presentations on host-parasite-vector interactions and sexually transmitted infections, as well as immunoprevention and control interventions. And two topics that span across all of these additional topics that I just mentioned, which are transdisciplinary engagement and data integration, including the important engagement with the communities affected by these diseases and climate change. We are very proud of the program that we have put together, and we hope that you enjoy the symposium and leave with new ideas or even new collaborations. Thank you all for joining us, and I look forward to an engaging and enlightening symposium. So with that, I'm going to leave it now to Giselle Viana, who is the organizer of the Malaria Conference.
Good morning, everyone. Excuse me, I would like to speak in Portuguese since we have the translation, and as one of realization of this second edition of our symposium. Eu gostaria de saudar todos os membros da composição desta mesa.
And I would like to greet especially Dr. Jeanne Marrazzo, because for the privilege of her presence here with us in Belem in the second edition of the symposium, Fiocruz and NIAID. Thank you for your availability to be here with us. It's with a great honor and happiness that we begin the second edition of the symposium between the two institutions that brings us an important topic about the global changes. And all of this is happening here in our vibrant city of Belem, which is known as a gateway of the Amazon. Today we are gathered here not only to discuss the challenges that we are facing regarding global health and facing these changes in the ecosystems. We are also here to strengthen our power of overcoming in cooperation, and especially the collective commitment for a healthier planet for everyone. In the next few days, we will have the opportunity to listen to national and international specialists, share scientific data, and also discuss the important strategies and effective strategies that might guide us in this meeting to mitigate risks to health, especially connected intrinsically with the environment. So this is a rich environment for a dialogue and exchanging ideas, and especially it's an inspiring environment. So before us we have challenges, but also great opportunities, and together we can promote these strategies and solutions so that we can reassure the well-being of our communities and the environment and the planet. We are looking forward to the next day's presentations, and we're confident that together we can make a difference. So we will begin this journey, this mutual learning and of an equal cooperation. Thank you for all of you that are here, and together we could make this event come true, and may this be a benchmark for this change. And I wish you all a very productive week and excellent work. Thank you.
Of Health and Human Services, HHS, and I'm based in Brasilia, and it's a pleasure to see this
Eu estou em Brasília, moro em Brasília.
Fiocruz Symposium
É uma
come to
prazer.
life. It's a testament to the powerful collaboration between our nations and the synergies around areas of mutual interest. On behalf of HHS and the U.S. Embassy, welcome to Belem. Bem-vindo. Today, I will cover 3 key areas: climate change and public health impacts, international collaboration for health resilience, and equity in a One Health approach. Climate change is amplifying health challenges worldwide, intensifying issues like vector-borne diseases, respiratory illnesses, and mental health concerns. In Brazil, extreme droughts and floods have fueled the spread of tropical diseases and disrupted water access, particularly affecting indigenous and riverside communities. In the U.S., climate-driven health threats are rising too, as diseases like West Nile virus and Lyme disease spread into new areas, and severe hurricanes displace communities and disrupt essential services. Extreme heat poses a growing risk, and we cannot forget about environmental health, as there are important issues that are not necessarily climate-related, such as lead poisoning. In Brazil, 1 in 6 children have elevated blood levels that are serious enough to require intervention, and this represents an improvement. Brazil has a very innovative battery recycling program, and so there's a lot to learn from how they've handled it here in Brazil. But lead is associated with 1.5 million deaths per year, and so the U.S., in partnership with UNICEF and others, are putting lead problems back on the priority list. To meet these challenges, the U.S. is prioritizing climate action through research, policy interventions, and global cooperation. HHS, including NIH and CDC, is leading efforts in disease surveillance and early warning systems to combat climate-driven diseases. We are investing in building resilient communities, promoting sustainable agriculture, and strengthening health infrastructure to handle climate impacts. Addressing climate-driven health threats requires strong global partnerships, and the U.S. is working closely with Brazil and other countries in the Americas. Initiatives like the Amazon Fund and the Amazon Malaria Initiative illustrate the power of resource sharing and coordinated action to tackle infectious diseases and environmental challenges. Our work in Brazil extends beyond infectious disease research. We're united in broader efforts to curb Amazon deforestation and address fires, floods, and droughts. Together with partners like USAID and the U.S. Forest Service, we're strengthening health systems and enhancing environmental resilience. And then equity. It's at the core of the U.S. approach to health, especially in addressing climate-related health threats that disproportionately impact vulnerable communities. A One Health approach, integrating human, animal, and environmental health sectors, is essential to build adaptive health systems. And yesterday was One Health Day. Last week, at the G20 Health and Finance Ministerial in Rio, Brazil's presidency highlighted health equity as a central theme. At HHS, we're expanding research into climate-adaptive public health and creating grant policies to support climate resilience. We're focused on health accountability and on creating inclusive policies that leave no one behind. So I'll share some examples of how the U.S. has fostered strong ties with the Americas, and together we're working to combat climate-related health threats. NIH has funded numerous studies and supplements related to health impacts of climate change. Several that are being implemented in Peru include adverse effects of climate change on air pollution, aeroallergen exposures, and asthma symptoms. Capacity building in climate and health in the Peruvian Amazon. understanding the health hazards of heat and air pollution, population exposure and vulnerability, and the resulting impacts of climate change. And then there's a joint study between Peru and Bolivia on infectious disease training. I believe it's in Bolivia, and it's a south-to-south training with Peru. And then in Costa Rica, we have an international training in environmental health over the lifespan. And here in Brazil, there's been a study on the impact of climate change and land use on snake bite envenoming in the Brazilian Amazon. And then for CDC, in Central America and the Dominican Republic, CDC's Acute Febrile Illness Surveillance Network helps identify emerging and re-emerging disease threats and strengthens regional collaborations. CDC works with ministries of health, agriculture, environment, and defense across the region to conduct One Health zoonotic disease prioritization workshops. And this fosters opportunities for cross-disciplinary surveillance, prevention, and control of zoonotic diseases. And CDC's Global Antimicrobial Resistance Laboratory and Response Network has been working closely with partners across Brazil to build laboratory capacity and develop new strategies for the expanding threat of antimicrobial resistance, which is worsened by climate. CDC is also providing technical support on an initiative out of Fiocruz and PAHO called Vigi Fronteiras, which includes training for strengthening health surveillance actions and services in the border regions of Brazil and its neighbors. This includes training on techniques for tracking population mobility patterns within borders, as well as screening. And then for USAID, the Amazon Malaria Initiative unites countries including Colombia, Peru, Bolivia, and Ecuador, and Venezuela to address malaria in the Amazon basin, an area particularly vulnerable to climate-driven changes. In Guatemala and Honduras, USAID has worked to strengthen public health infrastructure and disease surveillance systems in response to extreme weather patterns, particularly in rural areas where diseases like dengue and leishmaniasis are spreading more rapidly due to climate change. In El Salvador, USAID is working with youth to preserve natural resources in the Paz River area through mangrove ecosystems management and adaptation to climate variability. The Global Emerging Infections Surveillance Program, run by the U.S. Department of Defense, partners across the Americas to track climate-driven disease trends using advanced satellite and meteorological data to predict outbreaks of diseases such as Zika and chikungunya. The collaboration between the United States and Brazil and our partners throughout the Americas has never been more critical as we confront the challenges posed by climate change and its profound impact on public health, particularly the spread of tropical diseases. Together, through continued cooperation, innovation, and sustained commitment, we can create a healthier, more resilient future. So thank you to Fiocruz and to all of our partners for your leadership and dedication for this vital work. And I wish you a productive week. Thank you.
Bom dia a todos. Good morning.
I would like to thank the presence of all of you and congratulate all the organizers for this event, which is of extreme importance. And especially, I would like to thank Ms. Giselle Rashid. She's a researcher of Evandro Chagas Institute, who was leading the organization with Fiocruz and NIH, and that for us of Evandro Chagas Institute is extremely important to be here in this moment, for being an institution connected to the Ministry of Health, the Secretary of Surveillance and the Environment, and understanding the importance of what's going to be talked about these days. Not only what's about malaria, which is a very important a health issue in our country, and especially in the Amazonian region, but also all of the alterations that we've been looking in climate and environment that could impact not only the world, but directly the populations who live here. It is extremely important that we work in a coordinated manner together so that we seek the best solutions due to in this scenario that we've been observing. So congratulations to everyone involved in the organization of this event. I really wish that we have big learning days, big discussion days, and that we can look into how we can minimize the problems, the health problems that we've been facing in our region. So thank you so much. Institute Evandro Chagas is with our doors open for all of the fostering of these works, and we are extremely happy. Yesterday in Brazil, it was the One Health Day. So I understand that this is a very important role that we have to look, because the health problems are not only health problems itself. So we have to look in a globalized way to the strategies and solutions. So I wish an excellent event for all of us. Thank you so much.
National Institute of Infectious Disease, one of the Fiocruz institutes that has a long-term collaboration with NIAID. And I'm here representing Mário Moreira, the president of Oswaldo Cruz Foundation. Due to health issues, he could not be here, but he sent his welcome and the wish for a very successful meeting. It's a pleasure to participate in this opening of the second symposium of Fiocruz and NIAID. The thematic of this symposium is very timely. We are facing problems with climate, the problems of an impact of climate change here in Brazil and abroad. Every day we hear about problems caused by climate change. And we are also discussing issues regarding the pandemic preparedness. Fiocruz is a very diverse institution that involved in from basic research to production of vaccine, medicine, including healthcare, production of kits, and Fiocruz also work very deeply and continuous with the community. When we started the opening of this symposium, I would like to highlight the impact of the climate change in the lives of people that are very vulnerable. They live in poverty, in territories that are everything is lacking, and it's a good opportunity for us as researchers to discuss it. Nothing after so many time, so much time with online meetings, virtual meetings. Is very good. Nothing like a face-to-face meeting to stimulate, collaborate among us. We will have speakers from US, from Brazil, that will inspire us to in our discussions, and is our wish that we can strengthen our collaboration, our solidarity, and Fiocruz is committed to mobilize all its effort to stimulate collaboration in preparedness for future pandemics, and also to work on climate change, not only on research, but also the work on territories with vulnerable population. I would like to congratulate Leonardo and Ackerman, and to say thank you for our partners in Ministry of Health, the Evandro Chagas Institute, and to a special thanks for the presence of Dr. Jeanne Marrazzo. It's an honor for us to have her with us. So, very good meeting, and we will be here to talk with you. Thank you.
Bom dia a todos e a todas.
Good morning, everyone. It's a pleasure to be here in the opening of this symposium. I'd like to say that the Federal University of Pará is honored to be able to talk about such an important theme, which is global health and climate change. We are a university, a big university, a university that has more than 50,000 students, and we are in more than 80% of this huge state, the state of Pará. And we follow the challenges that are to think about health in the Amazon and the health in Brazil. We left a big pandemic, which made us learn so much and see how challenging it is to think about health in a perspective of climate change and social transformation in a region that is very challenging also, a region that we have all sorts of problems, geographic, anthropological problems, political problems, and we must understand health in its completeness. I think that any perspective of thinking about health in the Amazon, we must involve the subjects in the Amazon, the riverside communities, traditional communities, and understand how these people live and how they can survive to so many challenges which make this region that not long ago was okay regarding water and regarding rain. Today, this is a region where we are suffering the same consequences of the rest of the country, even the northeast of Brazil, when it comes to droughts. We have the ocean becoming a desert and the desert becoming the sea. So we have a big responsibility here in the Federal University of Pará. And we have two big health schools, one here in Belem, one that has all the areas in health, and one med course in Altamira. It's a very distant region, 1,000 kilometers from Belem. So we are a state that have one campus 1,000 kilometers away from each other. So it is a challenging thing, and it's important that we have strategies and elements to think on health and think on development from this logic, which is so complex in a country that is a continental size. And we must have this dialogue with a lot of understanding and a lot of assessments. We have colleagues from the Federal University of Pará, which are going to speak in this event. And I really hope that we talk about tropical diseases, but also try to understand how the world is developing and how the Amazon has been absorbing this reality. I really appreciate, in the name of the Federal University of Pará, I'd like to make ourselves available for dialoguing and to think about the future of the country without thinking on health also. Thank you so much for everyone. Good morning, everyone. I am Luiz Augusto Galvão. I work at Fiocruz, and I am part of a group in Fiocruz that we are having a new strategy of health of Professor Mário Moreira, our president, represented by Valdilea here. And I'm also working with NIAID. I am also professor in the University of Georgetown, and with one of my partner, we are always having conversations. And it's a pleasure to be here with Dr. Marrazzo, Dr. Kelly. We were together in G20 this week. I'm going to tell you just an example. This week we were together in bilateral events in different conditions. We started the week last week with a pandemic event and a climate event in Rio de Janeiro, organized by the National Medicine Academy of the United States, the UN Foundation, and this was a very successful event. And we also had G20 approving the two resolutions, the general resolution and the climate resolution, and also here in this amazing event with all of our colleagues together. So I'd say that we are heating our motors for COP30. We are in Belem. It's a wonderful city. I hadn't been here for years. It's a city that I really enjoy, and I appreciate the opportunity. That's all I wanted to say. I just wanted to communicate that Professor Mário Moreira is establishing a big strategy in health, which is going to add a lot, and we will be active for COP30. Thank you. We thank everyone who was part of this welcome. You might take your seats so that we can follow with our first session. For that, I invite Ms. Jeanne Marrazzo, diretora do
Beatriz Grinsztejn. I am an infectious disease physician and researcher based at Fundação Oswaldo Cruz in Rio de Janeiro, Brazil, at the National Institute of Infectious Diseases. It is my great pleasure and honor to introduce Dr. Jeanne Marrazzo. Dr. Marrazzo began her tenure as the 6th NIAID Director in the fall of last year, 2023. She oversees a 6.6 billion budget that supports research to advance the understanding, diagnosis, treatment, and prevention of infectious, immunological, and allergic diseases. She is highly internationally recognized for her research and education efforts in the field of STIs, especially as they affect women's health. Dr. Marrazzo's research is discovery in discovery and implementation science has focused on the human microbiome, especially as it relates to female reproductive tract infections and hormonal contraception, prevention of HIV infection using biomedical interventions, including pre-exposure prophylaxis, PrEP, and microbicides, and the pathogenesis and management of STIs. She is a member of the National Academy of Medicine. Over her scientific career, Dr. Marrazzo has led progressively larger interdisciplinary teams working to advance translational science in two major areas: approaches to detect non-cultivatable or highly fastidious bacteria in bacterial vaginosis, and oral and vaginal PrEP for HIV prevention in women. Working with behavior science colleagues to understand these responses, her team established the need for reliable biomarkers of adherence in intervention studies of young people in communities disproportionately affected by HIV. Prior to her position at NIAID, Dr. Marrazzo was the director of the Division of Infectious Diseases at the University of Alabama at Birmingham. There, she had the opportunity and resources to lead in the areas she cares deeply about: research in discovery and implementation science, the development and support of trainees, the advancement of underrepresented minorities in medicine and leadership, promoting meaningful dialogue with communities and patient care. It means a lot to me to introduce Dr. Marrazzo to address her lecture. We are so honored and proud to have you, Jeanne, with us here in Belém do Pará. Welcome.
Wow, it's a mutual honor to be introduced by the legendary Dr. Grinsztejn. So thank you so much. It's a real pleasure to be here in this incredibly beautiful venue. I'd like to thank all of you for being here. I'd like to thank the organizing committee, Leonardo, Giselle, Hans, and Joelle, for putting together what promises to be a very special program. And I'm really excited to talk to you today about the history of our interactions and what I hope will be the future of a continuing, very fruitful dialogue. I want to point out that there are many people in the audience who are much more involved in the science of climate change and also in much of the disease pathology and prevention that I'm going to talk about briefly. So you're going to get to hear a lot more after me. So what I'm going to talk to you about is a little bit of background about the NIH and the history and the future of our collaboration. For those of you who don't know, the NIH is situated with a main campus in Bethesda, shown here, and it comprises 27 institutes and centers. We have about 6,000 intramural researchers and over 27,000 staff. We also have the NIH Clinical Center, which is shown there in the red circle, which is the largest research hospital probably in the world and the only hospital dedicated totally to research. So you can only come there if you're on a research protocol. And of course, the National Library of Medicine is also situated there. When you look at where we sit in NIAID, you can see that we are one of those 27 that I mentioned. And the key points about NIH that I think you'll come to appreciate as we talk about our joint collaboration is that we have a vibrant intramural program with much representation here at this meeting, conducting research not just in laboratories but also in the community, I would mention. And then, of course, a very large extramural program. We are the largest funder of biomedical research in the world, and particularly across the globe. And I'll show you a little bit of that in a second. So what is our mission at NIAID? And what you're seeing here, I already showed you the Bethesda campus. On the left there is Building 40, which is our Vaccine Research Center. On the upper right is the beautiful Rocky Mountain Laboratories, and you're going to hear from Dr. Bloom later today. That's in Hamilton, Montana. And on the bottom there is our suites at Fisher's Lane, which is just north of the Bethesda campus. And our mission overall is to support and conduct biomedical research to better understand and treat infectious, immunologic, and allergic diseases. But we have a dual mandate, and we are unique in all of our sister institutes at NIH in that not only are we committed and authorized to maintain and grow a robust basic and applied research portfolio in the areas that I just mentioned, but we're also tasked with responding rapidly to new and emerging disease threats. And that's one of the most exciting things about my job and about the things that we get to do in collaboration with scientists and people like you. Because ultimately what we want to do here is to develop and implement new and improved interventions, whether they are preventive measures that we know we have needed for a long time, like a TB vaccine or a TB prevention program, but also medical countermeasures aimed at emerging disease outbreaks. And I can think of no better place to talk about that than in Belem and in Brazil in general. And I just want to emphasize that while many think of us as a basic science sort of focused area, that much of that science is then translated into widely implemented health interventions. And there are just a few here that had their origin in research that was initiated and funded at NIAID. I won't go through those, they're familiar to many of you. So I want to just point out that while we do have a general mandate, you saw that it's very broad, we are in the process of redoing our strategic plan. I know many people think strategic planning is boring. I'm probably one of the few people who gets very excited thinking about strategic plans, because to do it, you really need to think about how you're going to allocate your resources for the next several years and who your key partners are going to be. And you all know that that takes a lot of time. You don't just overnight decide you're going to work with somebody. You have to build trusting relationships, and you have to continue to nurture those relationships. Again, one of the reasons I'm so grateful to be here to open this symposium. So we have a few areas there that I just want to highlight. You know that we do the research that I mentioned. You know that we do pandemic preparedness. But we also are tasked with making sure we have a vibrant pipeline of people who can carry on the work after we are no longer active. And one of the most exciting things about this symposium, I think, is the grant writing workshop that's happening tomorrow, because we really want people to learn how to get our money, right? It's not our money, it should be your money, and you should be out there doing good things with us. We also are really concerned about infrastructure. You know, our infrastructure is especially things like our high containment, biocontainment laboratories. We have to be very attentive to keeping those in good shape. And then, of course, community engagement. We learned very painfully during the pandemic that if you don't have the community aligned with what you are trying to do to protect the community, then there can be all kinds of bad things, and that's a topic for another time. So our research priorities are going to continue to emphasize these 5 areas. The one thing I won't talk about in this talk, given the topic and also the fact that we're going to hear a little bit about it later, is our whole portfolio around HIV, but of course that is a very, very big part of what we do. But a reminder that we also have allergy, primary immunology, and transplantation medicine in our portfolio. So it's really very, very rich and diverse. Before getting into the specifics of our relationship, I'd also want to mention that we are more than about just the pathogens. We all have our favorite pathogens, whether it's a malaria pathogen, whether it's dengue, whether it's HIV, but there are so many cross-cutting issues that affect the likelihood that people are going to be affected by or indeed killed by an infectious disease, right? Health disparities, a huge issue, especially when you think about climate change, as Kristen just mentioned, right? The most vulnerable people are the people who do not have the resources to rebound, for example, from their houses being destroyed, or don't have houses in the first place, right? Women's health is a very big area, of course, that I have been interested for a long time, again, given vulnerability and lack of often self-advancement. Expanding research inclusivity, we really want to make sure that the people who are going to benefit or need the research the most are the people involved in conducting the research. And that is, of course, much harder than it sounds, and has so much to do with access to education and connections and networking. One of the things that the grant writing workshop, for example, can start to address. And then critically supporting global health. We cannot do the work we need to do in the United States alone. And you'll hear, probably in other conversations, that I spend a lot of my time talking to the people who authorize our budget, talking to the people who question why we do what we do, and making sure they know why international collaborations are at the heart of what we do is really a big part of what I do in terms of talking to our leadership. So, let's see, can I go back? I hope. Hang on a second. Great. Sorry about that. That was a very sensitive turn. Okay, so let's talk about what we have done both with you and globally. This is a slide that shows the NIAID budget starting way back in 1994 and through 2023. And the total budget, you can see, is in red there. Well, we have done very well in making sure we have the resources we need to get what we need done. I will say, though, since 2023, our budget has been totally flat, and that's in the face of a recent pandemic. So a flat budget is not a good thing, but that's another, again, issue to talk about. When you look at our international budget, I'm really proud to say that while we haven't managed to increase that in the face of our own total flat budget, we have managed to continue a very substantial commitment when you look at that total, and I'll show you those numbers in a minute. And you can also see that it's continued to climb over time, somewhat modestly, but again, proportionately, when you're talking about a $6.6 billion budget, it's a lot of money, as you'll see about. So how is our budget actually broken down when you look at our international expenditures? So as I mentioned, about 10% of our total budget goes to international research. That means about $700 million a year. Much of that, or just a little over half, is spent on HIV/AIDS, not surprisingly, 25% on biodefense, and that's a term that is defined by the people who allocate our budget, so it's actually more broad than you might think. And then about 20% on non-AIDS and non-biodefense. So much of the biology and the work that you're doing will fit into that. What about funding by region? You can see that almost 20% is coming to Americas and the Caribbean, about 41.5% to sub-Saharan Africa. So you are, in this area, by far the second largest recipient of our federal or international funding. Our global health research just last year, as I mentioned, totaled $700 million. And if you look at the top 10 countries outside the U.S. with funded activities, this is what you'll see. South Africa, the UK, Uganda, and Brazil, and then the countries below that. So a very large footprint across the globe, with some unfortunately notable exceptions for reasons you might infer. So we also, in addition to funding those countries and the investigators with bilateral agreements, have formal bilateral programs or agreements with several other areas. And those are listed here. And I'm going to talk about the one that we have with you, the U.S.-Brazil Collaborative Biomedical Research Program. But you can see you're one of only several that are formally set up and have been sustained over the years, again speaking to how much we prioritize our relationship with you. So we have a really long-standing research partnership. In federal year 23, we dispersed over $37 million to Brazil. There were both extramural and intramural projects many extramural grants as shown there. And I've just listed a number of our major supported programs and networks. And I will say that, as I'm going to highlight in the next few slides, some incredible work has come out of all of these networks, work that we could not have possibly done without you. I'm most familiar, before this job, with the HIV/AIDS clinical trials network and epidemiology networks, which are really legendary in the field of HIV, particularly in Brazil. But there are many, many more. So what has some of that research been? And I apologize if your work is not mentioned here. There's no way in a brief 30 minutes that I could cover everybody's accomplishments, but you're going to hear about many of those things today in this symposium. So, mentioning the recent pandemic, you were very, very important in understanding the genetic epidemiology of the epidemic here in Brazil. And this was from one of our networks called the CREEDS, the Centers for Research in Emerging Infectious Disease Network. You're going to hear more about that today. And this group really conducted the first detailed study of the genomic epidemiology of SARS-CoV-2 in Brazil, demonstrating that you could have a real-time genomic surveillance effort for emerging viruses in this region. Really critical to help figure out what to do in terms of interventions, of course, as the epidemic or pandemic proceeded. Tuberculosis, you may have seen just last week the WHO report 2024 showing that in 2023 the number of tuberculosis incident infections increased to over 13 million, a number very much up from the previous year of just up over 12.5. There has been a small decline in mortality reported in that report, but it's almost negligible compared to the increase in diagnosis. That actually shifted TB to become the world's largest infectious disease killer now, surpassing SARS-CoV-2, which had taken that ignominious title previously. So TB is just, I think, one of the biggest challenges of the next 5 to 10 years that we face, and I look forward to trying to help solve this problem with you. The report group, particularly in Brazil, has done some beautiful work in an area that I feel like, again, is this aspect of implementation science that we cannot ignore. Again, even though our focus is on basic research, you can make all these wonderful tools. You can make a magic pill. You can make a magic shot. You can make a magic serum. But if you can't get it to the people who need it, then you just are really not recognizing its potential. So I liked this study a lot, which looked at key factors of children and adolescents in Brazil who are lost to follow-up in the cascade of TB care, and really helpful when you're trying to figure out how to maintain an intervention that can save these young lives and will inform ultimately probably our approach to wielding even more effective biomedical interventions for tuberculosis. Some highlights of our recent collaborations are shown here. A Zika virus DNA vaccine studied by the Vaccine Research Center, the Zika and Infants and Pregnancy Cohort Study, the Virtual Collaboration Summit, I mentioned the grant writing workshop, and also, of course, our symposia, which I think are setting the standard for the presentation of science as we go forward. I mentioned the number of extramural research projects in Brazil, over 116 grants. Over 50 of those are NIAID-supported extramural research projects involving Fiocruz investigators. So, again, a powerhouse. And I think that we will need to continue to work together given the emerging problems we are seeing. Obviously, critical efforts by several of you in the ORAPUSH process, particularly the development of the diagnostic assay, which has received widespread acclaim. So what are some of the things that we're most concerned about? In this past year, it's been fascinating to see the emergence of things like H5N1, Mpox, now Marburg virus, ORAPUSH, all in a single year. of my starting in this job, just showing you how the pace of emerging infections is really relentless in the face of largely zoonotic spillover. What's underlying zoonotic spillover in a huge way? Habitat destruction and climate change, right? As you're going to hear from the climate scientists here, they are intimately related. And we estimate that approximately 75% of emerging pathogens are zoonotic. And there is no question that climate change is accelerating the disease emergence and spread. One other point I will make is that we used to be able to neatly sort of separate the outbreaks that occur in the U.S. versus not. And that's, of course, no longer happening, right? Borders are becoming immaterial when you look at change in the range of vectors and when you look at change and extended travel. So just a couple of words. You're going to hear much more from much more informed climate scientists this morning. But just a reminder that 2023 was the hottest year by a large margin. And I was just reading yesterday, 2024 is probably going to be on pace to exceed that. Why is this related to infectious disease? You're going to hear much more about that, but I really liked the climate change and epidemics synthesis report. If you're interested in a deeper dive in this, I highly recommend it. Remember, it's not just vectors, it's everything from more extreme weather events that displace people, that cause flooding, that causes dams to go down, which happened, of course, a couple of years ago, and also migration, and by not just people, but by livestock. So all of these things are critical. I really like this graphic. If you haven't seen it, what you're seeing here is mosquito habitat expansion, in this case Aedes aegypti, into the US and China in particular. But if you look at South America as well, you're going to see an increase by 2050 of the range of Aedes aegypti and the, of course, range of its associated infectious diseases. So this does not look like a very positive scenario if you're concerned about arboviruses or other mosquito-borne diseases. Kristen mentioned, and I just want to show you some data about this, that one thing that people I don't think are thinking about enough is that climate change is associated with increases in antimicrobial resistance. In the United States, people often think about serious AMR as something you get in hospitals, right? You go to the hospital, you go to an intensive care unit, and you get infected with a very bad bug. Actually, it turns out it's a huge problem in Pakistan, in the Far East, Singapore, in sub-Saharan Africa, now really becoming an issue. And there's a strong association between the increase in temperature and the increased prevalence of specific antibiotic-resistant bacteria. And we don't really understand why. Hopefully we'll hear more about that today. The temperatures may make it more favorable for bacteria to grow. It may make it easier for them to transfer genes from one another. So it's a fascinating idea and one that should make us very concerned. It's not just bacteria, it's also fungi, which I think was most evident. I trained in Northeast United States, where we had never had a case of coccidiomycosis. Cocci, you have your variant here, is a pathogen that is largely on dry areas in central California, and we now see it as far north as Washington State or the Canadian border. Why? Because the spores have been able to travel and they've been able to hang out quite successfully in regions that are farther north. So geographic range of these fungi is changing, dispersal is changing. We think that there may be vector change for some of these things, and there are also some very interesting signals that virulence, similar to the antimicrobial resistance world, might be increased by temperature. So very, very worrisome trends. And I'll finish up just by highlighting some of the programs that we have worked on together to address diseases exacerbated by climate change. I mentioned the CREED networks. 2 of those have study sites in Brazil, coordinating research on emerging arboviral threats encompassing the neotropics, or CREATE-NEO, And then, of course, UWARN, the United World Antiviral Research Network, and I think some folks are here from that. Our intramural program have led critical studies with you looking at 2 arboviral diseases in Brazil. I mentioned the TB003 and then the Zika virus vaccine. So very exciting work. And then, of course, Oropouche, which I think is one of the most fascinating outbreaks of this past year. I'm really not quite sure we've understood this whole evolution yet. Again, we have experts in this room who have dedicated many months to this in the last year. And we don't really understand what's going on here, although a recent WHO report does suggest climate change as a possible cause. If you haven't seen the recent New England Journal report with the photos of the neonatal abnormalities and the Lancet infectious disease reports, they're really stunning and should really make you pay attention to the potentially devastating effect, particularly for infants of this infection. And again, this recent preprint was published. This is coming out of the Creed UWARN Center, and it was a very large genomic epidemiology study that looked at the very first genomes that were available from here, and is giving us some hints about how this pathogen is emerging and spreading, and suggesting that climate change and deforestation likely played a role by expanding the very interesting vectors that are operative in Oropouche. So the other thing I just want to mention is that the NIH has a climate change health initiative that is run out of the National Institute for Environmental Health Sciences. NIAID is a critical partner. I'm actually on the executive council and participate regularly in the calls, which are really great. They have a relatively small ability to fund studies, but they're importantly starting networks, they're starting training programs, and they're working collaboratively with other institutes to develop a more comprehensive interdisciplinary research infrastructure and workforce, which I think is really critical here, because this is not just one disease, it's not just one infection, and it's not just one country. So it'll be very interesting to see how this group can innovate across the continuum to continually focus on this big problem. So the bottom line is the reason we're here is climate change is a global issue that requires international cooperation and the presence of multidisciplinary scientists and, frankly, activists who need to really advocate for awareness of this problem. And that's just sort of summarized in this slide. The last thing I'll say is that all of these are really great aspirational goals, and I mentioned this before. The research is critical, it's fascinating, the science is great, but if we don't have the people to do the work and we're not making sure we keep this pipeline healthy, which is really a passion of mine, then we're just not going to be able to get there. So I really want to end by thanking all of you, not only for doing the work you're doing, but also keeping young people, people who are underrepresented in science, people who represent the communities most affected by these conditions, involved in the research, involved in your labs, involved in your programs. And we are delighted to do everything we can to continue to support it. So I'll stop there, and thank you very much.
This one's on.
We'd like to welcome you to come down to the front, use the microphones to ask your questions of Dr. Marrazzo. I will say one of the things you recognize immediately is that she's a very good listener. So this is your opportunity to learn more, or perhaps share your perspectives on how NIAID should be interacting here in Brazil.
Hans also knows that I have a reputation for asking a lot of questions. So this is your chance to get back at me for asking all those questions, and I see somebody's taking advantage of it.
Us here is how do we demystify that it's so hard to cooperate and to collaborate with international institutions. I faced this during many years. It takes a long time to build trust with the region, and I think it takes time as well for them to feel empowered and come to us in equal grounds. And I think this is part of the work that I think is so, so important. So if you can share a little bit, what would you say to the folks who are here that it's fine to work, and certainly they know a lot that we can collaborate, and I think this is the key for success. Thanks very much.
My pleasure. Thank you for being here, and thanks for the question. I mentioned trust. You mentioned trust. Trust takes a long time, and a key component of trust is recognizing that there's going to be mutual benefit out of the collaboration, right? We're not here to take data. We're not here to publish things as first authors. We are here to develop the opportunity to move science forward together and to help build the infrastructure that we enjoy, and increasingly many of the places that we work with enjoy. I look back to my early involvement in the Fogarty programs in Peru, at the University of Washington, in Peru and in Kenya, and the generations of people who have now grown up, who are leading programs there, it's remarkable. Yes, those took decades, but I think we can accelerate that pace with the incredible advances in communication that we now have. I don't love Zoom, but let's face it, it makes things happen a lot faster. It is efficient. There's nothing like meeting in person. So I would say to you that, number one, you have to go into these relationships with a mutual understanding of what you're going to get out of it, and it's not going to be about either side. And if anything, it should be weighted towards the people in the places that you're trying to support. And it should be really thinking about not just the infrastructure that you've got, but also the people that you're trying to grow. The last thing I'll say, because you're from CDC, is that interagency collaboration is really important. So we have set up, for the first time, from what I can tell, this hasn't happened before, which I find astonishing, but Oropouche provoked us to set up a monthly call with Deb Howry, who is directly below Mandy Cohen, and a bunch of scientific leaders from CDC, as well as the leads from VRC, the leads from DMID, all of our divisions that are working on this project. And we have really started talking about, like, seriously, how do we get samples to each other? What are our mutual areas of expertise? Why aren't we talking about this? Because we all have offices in these places, and we all have access to different things. So I think a lot of it in the past has been around egos. It's been around turf. And I just don't think we have time for any of that. The world's on fire. We need to get along and figure out how we're going to do this.
Do we have more questions? Also, we have translators, so if you want to present your question in Portuguese, Dr. Marrazzo can hear the translation.
Should I? Okay. So, hello, good morning, everyone. Bom dia. I'm Paula Regis. I'm an infectious disease physician and researcher at the Oswaldo Cruz Foundation, the National Institute of Infectious Diseases, and also a bit of global health advisor to the president of Fiocruz. And it's just a huge pleasure, as Dr. Beatriz mentioned, to have you here with us. And then just not maybe simple question, but we see all the global health movements, pandemic-related, the pandemic agreement. And then my question would be, how do you see this biggest challenge facing as the director of NIAID, including repairing the trust in public health and the trust that, especially in such a polarized environment, how can we navigate in this world that is always changed also by political decisions? Thank you.
Just a simple question. to end. Yes, relationship repair and regaining trust. So I have a lot of thoughts about that, which we don't have time to talk about. But I think I'll tell you a background story that I hope illustrates what I at least am trying to do, and I think what many of us are trying to do. When I came into this job a year ago, you saw our budget. You know, it's flat. But I will remind you that when we get a budget proposal, we get three. We get the President's budget, the Senate's budget, and then the House of Representatives budget. Those budgets are often very much aligned with who's in charge of each of those entities. So when I took this job, the Senate and the President budget was flat, so no cuts. The House of Representatives, in contrast, proposed a 24% cut in our budget. So it would have been over $1 billion. And we were the only institute of those 27 that I showed you that had a proposed cut. What do you think that was about? I will just leave it to your imagination. I don't think I need to spell it out. But when you face that kind of mistrust and, frankly, hostility, you have a lot of work to do to make sure that doesn't happen again. And it didn't happen this year. In fact, the House proposed a 1% increase in our budget. Now, was that because of my charming personality? No. It was really because we had a concerted effort to reach out to people, talk to them about what we do, why what we do is so important, and more importantly, it's not about us. It's about what we do to protect communities, frankly, in the United States, because that's where they're focused, but of course, in our mind, globally. So my priority and our priority has been to sort of try to bring the temperature down, no pun intended, given our theme here, but to have sort of really focused, respectful conversations about, we all want to get to the same place. If we can acknowledge that and say, we don't want sick kids. We don't want moms dying. We don't want to see congenital syphilis, or furthermore, we don't want dengue coming to our borders if it gets to that. So I think if you can start having those conversations, you'll go a long way. I always also like to say, it can't just be me communicating this. It can't just be our scientists. It needs to be you. So you need to go out and talk to people about what you do, convey that you think it's important and why you're excited and why you think that you can make things better. Thank you.
Hello. I just want to add some small perspective and maybe a question about addressing some of these emergence and re-emergence of pathogens as if from nowhere. In my little experience and lifetime, I've seen a shift towards, I would say, situations that happen in the clinic and situations that are relying on remote and complex measures. But the real system where things happen are in the mud, in the field. And we are seeing little innovation, little investment in understanding of those, swamps, mental swamps, are not really swamps, where the happenings are really determining what eventually will come to the clinics. I think that there need to be some greater recognition that NIH does not have a disease ecology unit, essentially. And many others have seen very little innovation in this area because it's much easier to use satellite data and genomic data in clean labs. So I think that if we are not going to shift this, we will keep surprised. We don't have a clue about what are the vector of Oropush. We don't know enough about the reservoir host of all of this. And I think this is not by chance. So if we are not going to expand I would say, the system approach to it, I think we will be surprised. Thank you.
Thank you so much for that. I could not agree more. I feel like, in some ways, we are always in reactive mode, right? We react to data that, we call it sentinel surveillance, but by the time you get that signal, the cat's out of the bag. Whatever metaphor you want to use, the horse is out of the barn. You know, you've already gotten to a point where the disease has established enough of a cycle, a mechanism, a reservoir, etc., to put you at a position of vulnerability. So one of the things that I think is really important is, and this actually interestingly came up when I testified to our Appropriations Committee last spring. One of the members actually asked about this very question. Why aren't you figuring out earlier what's coming? Like, why do we always have to play catch-up and decide that we need a vaccine or a monoclonal against this thing that has already killed X number of people? I think that the centers that I mentioned, the CREED centers, also our CEERS centers, the Centers for Research on Emerging Infectious Diseases, the Centers for Excellence in Influenza Research and Response, they are great examples of creating models where you can invest in meaningful, intensive surveillance, not just of human signal diseases, but what's going on with the vectors and with the interaction with vectors in the environment. You know, the CEERS group is one of the groups that has been monitoring the highly pathogenic avian influenza virus in wild birds for years now. And it's without that database and without understanding what was coming where, we would have been even more unprepared when H5N1 emerged, and we would be even more unprepared if it continues to mutate to cause a pandemic. So I couldn't agree with you more. I'd love to talk with you more about how that should be scaled or could be scaled to improve that, that awareness, because we need that window into where things are coming from.
I think we have time for one more brief question.
Hi. Thank you, Dr. Marrazzo. We are here basically to incentivize cooperation between researchers and institutions. If I understood correctly, the programs you showed here are mostly funded by NIAID, by our extramural corporations, that's correct funding. And I'd like to know if there, NIAID and NIH in general has more specific cooperation programs between institutions. For instance, Fiocruz has a lot of similarities with NIH, of many of the approaches. If there's, for instance, agreements or cooperation and specific programs for funding between institutions, if you don't have, if you're considering establish this kind of mechanisms.
I think it's really worth talking about. We should talk about it. When you look at our intramural funding, when you look at our investigators, about 10% of our budget goes to intramural activities. So it's similar to the global proportion that I mentioned before. So in some ways, the breakdown for Brazil is very similar, right? It's a little bit more like 20-80. I think it's a way to solidify the relationships when you do that. And so, again, this is an opportunity to talk more specifically about where would you like to see those investments? What would they look like? What would they focus on? And what, more importantly, would the targets be for both developing the research teams and focusing on the pathogens that you think are most important? So happy to discuss that further.
So, thank you. I'm taking this opportunity here to changing gears to HIV. You know, Latin America is one of the very few regions where HIV infections are growing. And we have seen in the last years major advancements in HIV prevention. So we are having real difficulties in changing these achievements into practice, into implementation. Do you envision NIAID coming into implementation research?
Yes. In fact, if you start to follow or have looked at the blogs that Dr. Diefenbach from the Division of AIDS has done, foreshadowing the competitive renewal of the HIV networks, there will be a definite, I don't want to say shift, I think it's been a gradual evolution to recognize, again, that if we don't start thinking about delivery and access to the most vulnerable populations, again, we're never going to get this under control. One example of what we've done, and you know there's an End the HIV epidemic in the United States effort, has been allocating some of those funds to the Centers for AIDS Research, which traditionally have not been at all oriented towards that kind of science. So I think there's been a recognition that if we can't get the things to the people who need it, and we can't study that in a rigorous way, then we're not going to get where we need to go. So I think there will be, for sure.
Great. Well, I'd like to thank Dr. Marrazzo for spending this time with us.
My pleasure. Thank you so much.
So we move straight for session 1 on geography, physical disruption, and health. So I'd like to invite Dr. Jorge Nunu and Dr. Elena Marie Coeno to moderate this session, please.
Good morning, everyone. Welcome. Thank you again for the invitation, and congratulations to the organizing committee. This section is Geography, Physical Disruption, and Health. Our first speaker would be André Siqueira, but we are going to have Gabriel Valau from Institute Ageu Magalhães from Fiocruz, who is going to speak on Urupuxi outbreak here in Brazil. Thank you, Gabriel.
So let's see. So first of all, yes, my slides are here. First of all, I'd like to thank you very much for this opportunity. It's a great pleasure to be here in the second Fiocruz NIAID Symposium in this beautiful city of Belem. It's a big pleasure and also a challenge to replace Dr. André Siqueira here, not only because of his incredible scientific output, but also because he has a lot of experience working in the Amazon with several communities. But I hope I still will have some interesting slides that I put together here today, where I'm going to talk about arbovirus outbreak surge across South America in 2024 amid climate change. Let's see. Just trying out to figure out here. Okay, so these are the topics I'm going to address today. I'm going to talk a little bit about arbovirus burden and spread in South America. More specifically, I will address dengue expansion in 2024. I will talk also about West equinoencephalite virus 23-24 outbreak and challenges ahead. So before going deeply into dengue, because I know everyone is interested to understand a little bit more what happened this year in Brazil and South America, I just would like to briefly remind you about the climatic differences in Brazil. So as we all are experiencing here in Belem, Brazil is a tropical country with this warm and humid environment, but I have to remind you that Brazil also has a subtropical region in south of Brazil. You can see down the 3 states there, where in this right part of the graph, we do have well-demarcated seasons with winter, which eventually reach negative temperatures, right? And why I'm talking about that? Because this created what's known as a climatic barrier, a historical climatic barrier. So here we can see in the left part Aedes aegypti distribution back in 2007 in Brazil, and we could already notice the widespread distribution of Aedes aegypti across the country. But the southern part of Brazil remained almost free of Aedes aegypti because of this climatic barrier. And of course, when you look at the right side, dengue incidence, it was a mirror where the vector is, the virus is, and the population is. Then we had a lot of dengue cases from 2002 to 2012. Well, but what about the current situation? What's happening? It was amazing to see some slides before that introduced this problem of spreading of the disease because of climate change. Here we have a historical graph showing dengue incidence in Brazil. So as you all know, surveillance of dengue in Brazil is a relatively, we do have a relatively good surveillance system, and we do have molecular surveillance since '86. And you can see that more or less, in the bluish bars, more or less dengue fluctuated throughout the years, but it increasingly, the incidence was increasing year after year, right? It's also important to mention that we already detected here in Brazil all the 4 serotypes, sometimes co-circulating, or some other periods only 2 serotypes were detected. But particularly in 23, 24, I'd like to highlight two things. One of them is that we, because of improved surveillance, we quickly detect dengue-3 reintroduction in the country after a 15-year gap. So that was really concerning, and I'm going to show you that dengue-3 is already spreading, because after a 15-year gap, it's supposed that the population is now immunologically naive to this serotype, right? And when you look at the 2024, then we have this record of cases. Nowadays, we are topping 6.5 million suspected dengue cases, 5,600 deaths, and on the top of that, if we consider it, the estimates in the literature that around 60% of the population is asymptomatic for dengue, we can sum up more 9 million asymptomatic cases. And then we will end up with 15, 16 million people that got infected by dengue in Brazil only in 2024. So you can see the size of the problem, right? Well, I told you that surveillance in Brazil is good, right? Relatively good. We are not only performing surveillance for dengue, but also chikungunya, Zika, and also quickly expanding to Oropouchi and other arboviruses. But of course, surveillance can always be improved. And we, together with several other authors, implement a genomic surveillance for these high-impact viruses, like the dengue virus in Brazil. This is a letter we published last year with researchers from across the globe, representing 54 countries, which agreed to write and publish this call to leverage what we implemented during the COVID-19 pandemic regarding genomic surveillance for SARS-CoV-2, now for other endemic viruses. To then, we all would be able to profit about this high-resolution surveillance to monitor this virus in near real time. So it was really rewarding to see that here's the number of genomic sequences per country I extracted some years ago. And we can see that in Brazil, we are topping with 9,000 genomes available, and people are really contributing. So now we do have high levels of genomic surveillance from all states in Brazil. Of course, there is some heterogeneity, but we do have data from all Brazilian states. Well, let's have a look now on the genetic component of the dengue virus, what the data is telling us about. So here we have 2003 and 2004. On the left map, you can see this map comes with data only from serotype-only data. This data is publicly available, and diagnostic is performed by public health laboratories from every Brazilian state, and this data is available openly. So if we look at 2023, there is a higher prevalence of serotype 1, except by some states in the east and west part of Brazil, where serotype 2 was most prevalent. And you already can see over there a state with a higher prevalence of dengue-3, the re-entrance I mentioned to you before. But in 2024, only look at the serotype-only data, we can already see a shift, right? Now you can see more bluish pie charts showing that serotype 2 increased in frequency regarding the serotype 1. But of course, this is limited information, so when we add the genomic data, we do have more resolution to understand what is happening in terms of genotypes, lineages, and so on. So what we notice here is that, okay, TEV1, serotype 1, genotype 5 was the most prevalent for several years in Brazil, but back in 2021, DENV2, genotype 3 was the one circulating in the country, but from 2022 to 2023, we detected that DENV2, genotype 2, took place and replaced the previous genotype in the country, right? So here is just another graph to show you more clearly this pattern of replacement. So for genotype 2, we had serotype 2, we had the genotype 3 before, and then genotype 2 took over, and now genotype 2 is even outcompeting serotype 1, genotype 5 in the country. Why this is important? Because we already know about dengue. When we do have these replacements of serotypes, maybe we end up with more severe cases. There is a higher chance of co-infection, which we still don't know exactly what it means in terms of clinical aspects of the disease. But now that we do have this high resolution genomic surveillance, then we can perform monitoring for viral mutations that may change viral fitness. We can monitor new outbreaks if outbreaks are occurring because of new introduction of lineages, or those lineages are already endemic and fueling new outbreaks the next year. And of course, we can also evaluate if severity of the disease is also linked with some of the genetic aspects of the virus. Well, but what I'm going to tell you is that the prognostic is not good, right? We reached this record number of cases in Brazil, but the prognostic is not good. Why? Because, remember, linking back to my first slide about the climatic barriers, now we are noticing, since some 5 years back, that the climatic barriers are eroding. So currently, we do have the vector that is spread from, to all 3 southern Brazilian states, not only, but also to Argentina and Uruguay. And here is a study that tried to forecast the invasion of the dengue virus in the southern part of Brazil, and you can see that dengue will invade and likely become endemic in that region as well. So in the right part here, you can see the cumulative number of areas invaded, and the one that increased substantially was the south part of Brazil. Okay? What's the main issue here? Now we have the vector, we have the virus. There are some evidence already that we are currently generating and analyzing that there is no need for more importations. Now the virus is established endemically and fueling new outbreaks every year. And on the top of that, the human population, because it was historically not affected by dengue, it's immunologically naive. So we have all the main components for huge outbreaks to happen. And that's exactly what we are characterizing, right? So let's move to the next part. I will talk also about the West equine encephalite virus, another outbreak that occurred in Brazil, but also in the southern corner of South America. So the West equine encephalite virus is a virus from the Togaviridae, different from dengue, that belongs to the Flaviviridae family. And this virus, it circulates throughout the Americas. We do have more historical data coming from the US and Canada, and very few data in the past from Argentina mostly. So this virus in North America circulates endemically. The main reservoir are wild birds, right? And there are some of the vectors like Culeus tarsalis in North America that participate as a vector, transmitting to rodents, but eventually transmitting to equines and humans, right? In South America, there are some studies characterizing the vector. This is another vector, Aedes albifasciatus. Usually this is a mosquito from swamp regions. And when there is an increase in rainfall, and those swamp regions increase in volume, then there are population bursts of these mosquitoes that usually underline the spread of the virus to equines and humans. So here is the historical data I told you about. West equine encephalite virus was detected in all those countries in the left. In the US, it was shown that many cases occurred, many outbreaks occurred back in 1964, 76, and 88. But then the case decreases substantially, right? And there is almost or no cases reported up to now. And what about some of the clinical aspects of West equine encephalite virus? So West equine encephalite virus, the name is already saying, it impacts substantially equines, leading to encephalitis and death. But for humans, usually it's asymptomatic or mild, showing typical arbovirus symptoms. However, VEV may cause cerebral and meningeal inflammation, and the case fatality rate in humans is between 3 and 7%. But the current outbreak in South America, the southern cone of South America, 108 confirmed human cases were already detected with 12 deaths. In Uruguay, 5 confirmed human cases were detected with no deaths, and the CFR was 11 and 0 for Argentina and Uruguay. So with several collaborators, we start to deploy this high-resolution genomic surveillance to characterize this outbreak between 23 and 24. Here's a study that we retrospectively assessed samples of equines, that diseased equines that were first screened for rabies virus, but then we screened for West equine encephalite virus. And we detected 3 equines from these municipalities that border Uruguay in southern Brazil were positive, and we were able to sequence the full genome of the West equine encephalite virus. So looking at the phylogenetic tree, here you can see 2 main clades, the North American clade from these outbreaks that went down and almost disappeared in North America. And here below you can see what now we call South America clade. So in South America, previous to this study, we only had 3 genomes available, 2 from Argentina from 58, right, and 1 from Guyana. And then we added these 3 new genomes and some other genomes that are generated from by public health labs in Uruguay. So before 23, only 3 genomes. We added new 3 genomes, and we characterized this new C lineage that were circulating, showing that it was not a reintroduction of North America, but a new outbreak of this lineage that were endemically circulating South America in the past. And this is another study that we put together with several collaborators from Uruguay, where we investigated VEV outbreak specifically using equine samples from Uruguay. And in Uruguay, it was really interesting because we managed to put together not only genomic sequences, but all the epidemiological data associated to it. And we could see 2 waves of infection from November 23 to January 24. First wave that were more related to that map over there, where most cases were concentrated the left in the west part of the country, which borders Argentina, and the 24 where the virus were more widespread and spread to east of Uruguay, showing that probably the virus arrived from Argentina to Uruguay and is spread west to east in this case. And here we managed to sequence more 15 VEV genomes, from all of them from equines, showing that we characterized 3 main lineages with specific amino acid mutations, showing that these viral genetic diversity were already circulating endemically, and probably the surveillance systems were not able to detect it. But during the outbreak, we detected these 3 lineages, showing that they spread countrywide in Uruguay, and 1 clade clustered, the genomes clustered with sequences detected in Brazil. So, and in this case of West equine encephalite virus, there is not only a coincidence, because it was also linked in previous publications with the El Niño event. So during the El Niño event, we do have more rainfall in the southern part, on the southern cone of Brazil. There are clear reports of population burst of Aedes albifasciatus. I told you this before. And then many cases were associated with equines and also with humans. And many of this rainfall went down from September 23 to March 24. So here are my take-home messages. We detect substantial arbovirus burden in 2024 in South America. And of course, you probably noticed I'm not talking about Oropouchi because I have excellent colleagues that will address this today. But for those two viruses, there was substantial activity in Central America. Dengue expansion is linked to long-term climate change, that we saw this erosion of the climatic barrier, and now we are seeing increasing and new outbreaks in the southern part of Brazil and also north of Argentina and Uruguay. West echinocefalitis were associated to El Nino, which is a more short-term climatic event that may or may not be affected by climate change, but it's clear this association as well. And arbovirus continue to impose a heavy burden to the vulnerable population in South America. With this, I'd like to thank you very much for the opportunity and happy to take your questions afterwards.
Thank you very much. As I was telling to Gabrielle, the questions and answers will come afterwards, so hold on to your horses, uninfected hopefully, in the next talk. So the next talk will be given by Maria Elena Crespo Lopez, who's I think from Universidad Federal from here, Belem, who will tell us about environmental pollution versus public health surveillance in the Global South, and she would particularly concentrate on mercury. Thank you.
Good morning. Good morning. My name is Maria Elena Crespo Lopez, and I'm from the Federal University of Pará, here in Belem. As we have translation, I'm going to change to Portuguese. Profesora titular.
Our group, I am a professor. Our group takes more than 20 years talking about mercury in the Amazon, and specifically working with vulnerable populations affected by this problem in the Amazonian region. I appreciate especially the opportunity to be here talking to you about this theme, and especially to Leonardo for the invitation to be able to present this to you. So my speech today will talk a little bit about the current scenario related to mercury, and specifically the Amazon, and why we should care about this. Why do we have to talk about mercury? This is a death threat worldwide. We need to talk about mercury. Currently, we have more than 9 million deaths worldwide, specifically related to contamination, and among the main causes of them, contamination of air and also the exposure to toxic substances as mercury. These deaths affect especially the low and medium income countries, where more than 90% of the deaths are related to pollution. Among the toxic substances classified by CDC, mercury is among the 3 first ones that worry the most the public health, and they are classified above pesticides or hydrocarbonates, for example. And why? This priority is due to mercury being super persistent in the environment. The European Environment Agency has declared that even if tomorrow all the anthropogenic activities that emit mercury to the air will finish, it would take centuries for us to really go back to fix the mercury in a significant way. So we will have a long time of exposure to this problem. Besides that, mercury can travel long distances by air. We know that much of the mercury detected in the air in the Arctic Pole comes from South America. So if the South America mercury is getting to the Arctic, The Amazonian mercury is getting everywhere in the South America. And this is important because before the pandemic, Brazil was among the 5 countries that most emitted mercury to the air globally, and specifically among all the emissions of South America, 80% are originated in the Amazon. So the Amazon has a global impact of all the emissions of mercury reaching very distant regions. So all the things that happen here in the Amazon will impact other continents. And the problem is that currently we are in a new gold run due to the price that gold is reaching inside Brazil. And we have to reinforce this because we had never seen such a thing as now. We always talk about the gold runs in the 70s and the 80s, but you have never seen the magnitude of what is going on currently in the last years since the pandemic, on the opposite of what happened in other countries where economic activities stopped. In Brazil, there was an explosion of the activity of mining activity since the pandemic, and that continues till this day. And we can see that easily, that we have many registration along the activity emitting mercury in the Amazon. We hardly can classify that as something artisanal or a small-scale thing because it uses heavy machinery and airplanes and excavators, dredges, and it transformed into a public health issue. One very important thing is that the Amazonian forest, when it's intact, has the capacity of fixing mercury from the trees. So it protects us when there's big emissions, partially at least. The problem is that since the pandemic, we have been witnessing the deforestation and the fires. And about the deforestation, we already know that big part of it is due to the pressure of exporting soy and meat to Europe and the US. So this is a big tip about the international pressure, a big opportunity for international pressure about the origins of soy and meat bought from Brazil, and that there's international pressure to reduce deforestation, especially in the Amazon. All of the fires and deforestations, they throw mercury in the air, and mercury, when it's in the air, it can go back as rain. When mercury reaches the water, it will be transformed in organic mercury through bacteria, and it gets into the food chain, and then it biomagnifies with the tropic levels of this chain. And in the Amazon, besides the mining activities and the deforestation and the fires, what is leveling up with the climate change, we have other factors as the hydroelectric dams. We have one of the biggest dams in the world, which contribute for this mobilization, because when we reach an environment, they create the conditions, the physical chemical conditions for the bacterial proliferation, which have organic mercury, and it avoid the big migrations of the Amazonian fishes. So there are a lot of bioaccumulation in these environments. I must remind you that in an environment that is contaminated, we will find the biggest amount of mercury in people. So people are what we have to detect a contaminated environment. And what does mercury provoke in your body? Well, it can cross the mesencephalic, the fetus, the nervous system, but it can get anywhere, so it can affect many organs inside the body. And we always attributed neurological problems, but currently we have some meta-analysis that show that low doses of mercury are associated epidemiologically to the rise of the cardiovascular diseases, for example, as hypertension. So the diagnosis, especially here in the Amazon, so when you find someone with hypertension, you will never think about mercury. So this is one of the biggest difficulties for the health surveillance. The diagnosis or the suspicious of exposure to mercury is mandatory, just like many infectious diseases, for example, as COVID. And the diagnosis has to be registered mandatorily by the health professional in the system of notification, which is the same system that we use for many infectious diseases. And in this system, you have a file. And the first difficulty, besides the diagnosis, obviously, is that this file has to be mandatory and filled with the code T65.9, which is a not very specific code. It's a code for any type of intoxication. So with this same file and the same code, we register cases of exposure to pesticides, drug overdose, and it makes it very hard, the visibility of the cases, of exposure cases. So this is a challenge for us to understand what was registered officially in SINA in all the history. We had to look file by file almost manually to revise all of them and try to find the cases that could be related to mercury. We did not limit ourselves only when mercury appeared. So they were registered as maybe thermometer breaking or any lamps that could be broken. So when we found that mercury was related, we studied that. And for our surprise, we found little cases in this it was 668 cases in 16 years, so that's under notification. So we had cases all over Brazil of this problem, but specifically what was alarming was the under notification found in the Amazon, where we have the main emissions of mercury to the air. As an example, if you see the state of Amapá, if you see the state of Amapá up there, they have never registered any cases of mercury infection. So when they have historic illegal mining areas, so in the state of Pará, where we have some of the biggest dams in the world, where we have some of the illegal mining regions, and we have a lot of deforestation and fires, we registered only 4 cases. So supposedly, SINA is used for the efficient distribution of resources in the health surveillance. And according to this data, it would be impossible to have a location of resources as a strategy. For example, here in Pará, as I mentioned, we have one of the biggest regions historically of illegal mining in the Tapajós area, and we have many studies showing the exposure to population of vulnerable populations to mercury. We have decades of studies showing that they show levels that are way above what is recommended by the World Health Organization. And in all over the Amazon, science has shown that we have many cases of people where the levels of mercury are related to the symptoms that we found. And the symptoms, especially neurological, are about the motor alterations, visual deficits, impairment memory, ataxia, and something very important, which is a problem of mobility in children. And this is especially important because with the data that we have registered in Sinai, we found kids intoxicated by mercury. So we need that the surveillance of this problem to overlook to these ages. Besides that, it's very important, as I mentioned, that the mercury can, as I said, the mercury can get into the placenta region. So it's very important to focus in women in fertile ages. Something that really scared us was to find that a significant percentage of cases of women in fertile ages where they had registered as unknown their pregnancy state. So the first thing we must look when there's any any suspect of mercury is that is a pregnancy test, because the measures that we must have when the women are pregnant are very different. And this is not something that we have in Brazil. Doctors are not ready for this. And I must remind you that this is not a specific problem of the Amazon, our state. The state of Pará is the main exporting state of fish for other countries and all over Brazil. So what we are finding here with this fish and about food can be found in other regions where the fish, the Amazonian fish, the fish from Pará is getting. So we must urgently make some measures. We have some of these measures, as an example, using a specific code for the exposure of mercury and intoxication, so we can make it sensible for professionals, especially for the communitary agents of health, which are extremely important in the Amazon because they are the ones who really are able to reach the most isolated regions and the ones that know the most the populations and the communities, so they can adapt things as questionnaire and food questionnaires so they can have detection of the cases. We also have to raise the number of neurologists and cardiologists in the Amazon. We also have to establish Brazilian guidelines for the ingestion of mercury, especially in kids and pregnant women, as an example of what happens in other countries, as an example Spain. And also we have to improve the local infrastructure so we are able to measure the mercury. Currently, we have a scenario where we are not aware about the interaction of mercury and many infectious diseases. So we have conditions happening simultaneously, and we do not have any way to measure mercury in many regions in the Amazon because we do not have equipment. So we started acting since the pandemic to this point. We started acting in some actions, so we try to implement. One of the things that we had in collaboration with the Amazonian Network of Clinics and Human Rights, we elaborated a law project for the implementation of a national policy of prevention to exposure of mercury. Today, this is in the Senate, and it's open to voting. So I would really appreciate if you voted it. And we focused especially in health. So in the training of health professionals, in the awareness campaigns of a population, and the visibilization of notifications so we can really have data that can function for the public strategies and public policy strategies. Another initiative of the Amazonian Institute of Mercury, which is integrating the resources of many Amazonian universities to add efforts to implement testing areas in all Amazonian region in a uniform way that allows us to compare the assessments. And I just need to give you a challenge here. We know very little about the interaction of mercury and the infectious diseases. These are conditions that are happening simultaneously, and many times, for example, as in COVID, we have a potential synergy regarding these symptoms. So it is necessary to advance in the research and the interaction. Thank you so much.
And her lecture is Landscapes of Infection, the Role of the Environment in the Shaping Host-Pathogen Interactions, Life History, and Pathogen Transmission.
Hello. Thank you for the organizers for inviting me to speak today. I'm an associate professor at Cornell University in the Department of Entomology. I'm an ecologist by training, and my group is really interested in understanding the climate drivers of mosquito-borne disease transmission. And we do this by blending experimental work in the lab, semi-field experiment, and descriptive studies from the field with mathematical models to forecast how mosquito-borne disease will change in the future with climate change and with land use change. Okay, so there are three ecological factors primarily that shape the distribution of vector-borne diseases. These can include a wide range of environmental factors, such as abiotic factors like temperature, relative humidity, precipitation, and a wide range of biotic factors that can influence mosquito populations. We also have genetic factors that can influence, we have genetic variation in both mosquito and human populations that can influence how susceptible these populations are to acquiring an infectious disease and transmitting. And then we have a wide range of socioeconomic and human factors that can influence people's exposure to mosquito-borne disease. So these things can include quality of people's homes, how pervious they are to mosquitoes, water storage practices around the home, and access to public health care. And these things integrate to influence where mosquitoes are present in the environment, their abundance, our contact rates with mosquitoes, and ultimately transmission. And then these things scale up to influence the global distribution of vector-borne disease. Now let's layer in what we're doing to our environment currently. We've heard a lot about this already. So I'm going to talk a bit about urbanization. It's the fastest growing landscape on the planet, and urban environments are experiencing increasing intense urban heat island effects with climate change. And this is leading to explosive outbreaks of arboviral diseases in tropical megacities that combine conducive environments with high population densities. And we're also seeing the invasive spread of urban vectors like Anopheles stevensii into cities in Africa, which is problematic because it's potentially setting up a whole new zone of transmission in cities in Africa when malaria was originally, is mostly a rural disease, complicating malaria elimination efforts. And so much of the work that we've focused on to date in this field, when we're thinking about climate change, has been focusing on the effect of temperature. And this makes sense, especially in the mosquito. This makes sense. Mosquitoes are integral to the transmission process, and they're small ectothermic organisms, so temperature is going to influence their development rates, their life history, their fitness, and population dynamics. And laboratory experiments that have been done previously show that many of the traits that are important for the transmission process are really affected by temperature. So these things can include traits that drive mosquito population dynamics. So we have temperature effects on mosquito lifespan. We have temperature effects on mosquito fecundity. And then we have temperature effects on juvenile traits like egg to adult survival, as well as the mosquito development rate. We also have temperature effects that shape mosquito blood feeding rates and human contact rates. So this is how temperature influences the daily biting rate. And then we have temperature effects on parasites and pathogens that are developing within the mosquitoes. So the proportion of mosquitoes that go on to become infectious is affected by temperature. So that's vector competence, BC, up on there. And then also the pathogen or parasite development rate. And so what you can see is that, like in other ectothermic organisms, temperature has a strong nonlinear effect on the trait performance of these traits. So we have a minimum and maximum temperature that constrains the performance of these traits, and we have an intermediate temperature that optimizes performance of these traits. And what has been done previously is we can use statistical models to fit relationships to these temperature trait performance relationships, and then we can integrate these into mathematical models or mathematical expressions like you see here derived from these models. This is for the basic reproductive number for a vector-borne disease. And we can use this to predict how temperature will influence the transmission process. And when we do this, for example, for malaria, as this model is here, we can see that our prediction for transmission potential is also nonlinear, with transmission potential being maximized around 25 degrees C. And then we can use these mechanistic models and we can apply them to novel scenarios. So for example, we can use this temperature-dependent model to understand how environmental suitability in the invasive range for Anopheles stevensii in Africa compares to the native rural vectors in the Anopheles gambiae complex. And we can see that this model would actually predict that there's more environmental suitability or months of suitability for Anopheles stevensii. So there's more red and orange colors than for Anopheles gambiae, which is really problematic if this species continues to invade for malaria elimination efforts. And then we can also look into the future. And so this model has been used to explore how future climate change might affect the global suitability for Anopheles stevensii in the invasive, the native range, and potentially other zones of invasion. And we can see that even in areas that are permissive currently and on the warm end, we do see some contraction in predicted months of suitability for Anopheles stevensii, but overall, even under severe warming scenarios, we see a lot of suitability for stevensii. So we still see a lot of orange and red colors on these maps. So today I'm going to be talking to you about Indian cities, and I'm going to be talking to you about the urban malaria Anopheles stevensii system. And I will emphasize that the framework that we're using in Indian cities can be applied to other tropical megacities to understand the transmission of other urban vector-borne diseases. So Anopheles stevensii thrives in these really densely packed urban environments. And we have adults that feed primarily on human and cattle, and then they rest indoors in cattle sheds and in our homes, especially if they're mixed dwellings with cattle sheds abutting up to homes. And then the larvae develop in artificial water storage containers and in construction sites and shallow pools of water that are produced from the concrete curing process. And so what's interesting here is they're really detached. Their dynamics are really detached from precipitation because they develop in water that we continuously provide throughout the year. And then previous work in this system has demonstrated that there are other abiotic factors that are really important to consider in addition to temperature. So this work was done by Mercedes Pascual, one of my collaborators, and she's shown in Indian cities like Surat and Ahmedabad that we have these really strong relationships with relative humidity and the number of both falciparum and vivax cases. I'm showing you falciparum here. And then when we actually build semi-mechanistic models where we allow them to be driven by various climate variables, we can see that models that are driven by relative humidity do a really good job predicting the interannual dynamics of malaria cases in these two Indian cities. So this is for Ahmedabad. And so we've got time on the x-axis, and we've got observed monthly falciparum cases on the y-axis. The black lines correspond to the actual data, and then we've got the within-fit model predictions in purple, and then the out-of-fit model predictions in green. And you can see that relative humidity is really good at predicting when an epidemic occurs as well as the magnitude of the epidemic. And temperature is really important for determining the seasonality of epidemics. Now, the problem, if we're working with mechanistic models, which is the flavor of model I'm working with, it's really hard currently to incorporate the effects of humidity into these models in a quantitative way that we have for temperature, because while there has been experimental work done in the lab on this, it's been of limited resolution. So it's only been done across a handful of humidity levels and also a handful of mosquito species. And this leads into the framing of our current grant that's funded by NIAID, so thank you very much, that focuses on redefining the thermal suitability of urban malaria transmission in the context of humidity. And so the first aim of this grant, which I'm going to be talking a lot about today, is some of the laboratory experiments that we're running at Cornell, where we're trying to recharacterize thermal performance for these traits in the context of humidity. We're then planning on building these relationships into mechanistic models that I just showed you previously to see if we can better predict the interannual variability of malaria cases in these cities. And we're going to also use these relationships to build spatial risk maps in these cities that we can then use to help target surveillance and control in a proactive manner to try to get these cities across the malaria elimination threshold. And then this is a multi-institutional project. We have 7 institutions, 4 U.S. institutions, and 3 institutions in country that we're working with. So Cornell University is the lead. We're partnering with at New York University with Mercedes Pasquale, University of Oklahoma with Mike Wimberly, and then with Dr. Rimdan Nandi and Deepshika Bethesda from One Health Trust. Our in-country partners, the National Institute of Malaria Research. So the main PIs on the project are Dr. Rahendra Baharia and Ajit Mohanty. And then we also are working with local governments, the municipal corporations in Surat and Ahmedabad, primarily with Dr. Kashav Vaishnav at the SMC and Mr. Raj Sharma at the AMC. And so aim 1, like I said, that I'm going to be talking to you a lot about is the work that we're doing at Cornell, where we're trying to we're basically doing these very large experimental studies in the lab where we're putting mosquitoes in across 8 to 9 different constant temperatures and 5 relative humidities, and we're trying to recharacterize the thermal performance of these traits in the context of humidity variation. And so what we found is that humidity is having a pretty big effect on many of the traits that we're measuring so far. So I'm going to show you work from some of the larval experiments that we've done. We haven't allowed, so I'll be happy to talk about experimental design, et cetera, afterwards, but I kind of cut that out currently for the sake of timing, so I'm just going to show you the results. So we basically put larvae in 1-liter trays across these different environmental treatments, and we didn't allow for evaporation, so we topped the trays off every day with water. And then we looked at how quickly they developed, as well as their survival. And so what you can see here, this is per capita development rate. And so we've got relative humidity in different colors. So high humid environments are in blue, and then low humid environments are in lighter blue. We have temperature on the x-axis. And so what you can see here is that as humidity decreases, we get shifts in thermal performance toward warmer temperatures across the board. So we're seeing 7-degree shifts in the predicted thermal minimum. We're seeing 2-degree shifts in the thermal optimum and 2-degree shifts in the thermal maximum. And these shifts are huge. These are really big shifts and kind of unexpected since these are aquatic stages. If we're looking at the proportion of juveniles surviving, we also see the similar trend. We have, as humidity goes down, we have shifts in performance toward warmer temperatures. So we have a 3.5-degree increase in the thermal minimum. We have a shift, an increase in the thermal optimum, and we have a 7.5-degree shift in the thermal maximum. So what that means is that mosquitoes developing low humid environments can develop at much warmer temperatures than those developing at high humid environments. And then if we look to see how this affects body size, and body size is important to consider because it determines their potential fecundity as adults, as well as their ability to vector pathogens. You can see that we're seeing corresponding shifts in body size as well. So, we see a negative relationship between temperature and wing length. That's expected. You develop more quickly, you come out smaller. But that variation in relative humidity is shifting that relationship. So as relative humidity becomes drier, we're seeing kind of a buffering of that effective temperature. And then when we consider the adult traits, so here we looked at lifespan, we looked at biting rate, and we also looked at egg production. Okay, you can do it. We see that variation in relative humidity has more subtle effects. So for lifespan, we actually observed effects of relative humidity in ways that we would predict. So here, with adult lifespan, as humidity goes up, especially on the warm end, mosquitoes are buffered at warmer temperatures. And this is probably because they don't desiccate as quickly. So we don't really see an effect of relative humidity variation at cool temperatures. And we see a bigger effect at the thermal maximum. And then that corresponds to a shift in the thermal optimum. Interestingly, when we look at egg production, you can do it. Okay. There we go. Okay, so if we look at egg production, we see something sort of surprising. So as relative humidity goes down, again, we're getting shifts in the thermal maximum toward warmer temperatures. For the Tmax, the Tmin, and for the Top. So what this tells me is that maybe because mosquitoes aren't living as long at these warmer temperatures and in drier environments, they might be front-loading their egg production earlier in their lifespan, so they're producing more eggs on a daily basis. And then if we're looking at biting rate, we don't really see an effect of relative humidity. This is not entirely surprising because when we do our blood feeds in the lab, we're kind of hitting them in the face with a blood meal. If we made them actually forage for hosts, in a variable humid environment, then this could potentially show up as being important. But what we can say is that relative humidity variation is not changing how temperature is impacting the gonotrophic cycle and the inherent need to feed. Okay, so we're working on the parasite traits right now. I don't really have anything to show you because we're very much in the weeds in this experiment. But we are seeing some interesting effects of humidity on mosquito susceptibility and capacity to transmit malaria. Oh my goodness. Okay, so the bottom lines from this is that decreases in relative humidity push thermal performance for juvenile traits toward warmer temperatures, 2 to 8 degrees C. That's massive. So those maps that I showed you in the beginning of the talk, the difference in thermal performance curve, for example, between Stevens Eye and Gambia that generated those maps was about 2 degrees C along the Tmin and Tmax. So the fact that we're seeing an 8 degrees C shift is huge. And we think that this could maybe be because of how relative humidity and temperature affects surface tension of the juvenile environment, water temperature, maybe some other intrinsic property. We saw decreases in relative humidity had mixed effects on the performance of adult traits, with reduced longevity and boosted fecundity at warmer temperatures and metrics of parasite fitness probably. And then when environments are stressful, females produce more eggs earlier. Okay, and these effects are large. So I would expect that variation in relative humidity is going to significantly shape thermal performance for mosquito fitness, population dynamics, and pathogen transmission. And we're going to have to start considering how temperature and relative humidity interact in our forecasting of how climate change, for example, is going to impact the spread of mosquito-borne disease. Oops. Okay, well, so I'm going to give you some preliminary data from AIM-3. So AIM-3 is where we're trying to build these spatial risk maps for the Indian cities that we work in. And so as a first step, what we're doing in the field is we've gone out to both of these cities and we've set up microclimate data sensor networks. And the reason why we're and so what this looks like is we've gone out across roughly 48 sites in Ahmedabad and 45 sites in Surat. And we've distributed these data loggers that keep track of temperature and relative humidity. And we're doing this in indoor and outdoor locations where we find Anopheles Stevens Eye. And the reason that we're collecting microclimate instead of working with remotely sensed products or local weather station data is because we want to characterize the climate that mosquitoes are actually experiencing. And we want to do this at spatial scales that are relevant for the transmission process and for control. And then what we're planning on doing is we're going to take these, we're going to use statistical models to downscale macroclimate data to the microclimate data that we're collecting. And we're going to also consider the effect of land cover and land use. And we want to build interpolated spatial microclimate maps of our cities. We haven't done this yet, but this is where we're going. And I've included a paper up here for where we've done this in the Aedes albopictus dengue system. And then we're going to basically be using our transmission potential model that's now going to be a function of relative humidity and temperature to make environmental suitability maps of Surat and Ahmedabad. So where we are because we don't have the relative humidity data yet. I can do this for temperature because we have temperature-dependent models for malaria, and we also have temperature-dependent models for dengue. So this is an example of what the microclimate looks like in indoor and outdoor places in both cities, the average diurnal trends for May and June. And so we basically feed the temperature data into temperature-dependent models. And I'm going to show you some results for malaria and dengue about how suitability shifts across the season and across space. I know, I'll be good. Okay, so this is spatial variation in thermal suitability for dengue and malaria. So we have dengue in purple, we have malaria in green. We have indoor microclimate, indoor environments up top, and outdoor environments below. We have 3 seasons. So in India, the pre-monsoon season is really hot and dry. The monsoon season is warm and wet, and the post-monsoon season is cooler and drier. And we've got vectorial capacity. So greater vectorial capacity is increasing circle and increasing color of the circle. And each point corresponds to where we have a site with our data loggers. And so what you can see is that the size of the circle and location of the circle varies from indoor and outdoor environments and seasonally. So in the pre-monsoon season, you can kind of see that, if you're squinting, that thermal suitability for both of these pathogens might be a bit higher in indoor environments than outdoor environments, and that you have substantial variation in thermal suitability across the cities. In the monsoon season, you can see that thermal suitability overall increases for both dengue and for malaria. And again, this is more prevalent in indoor environments than outdoor environments. And then in the post-monsoon season, you can see, interestingly, it seems like dengue suitability picks up, in that we don't see a big difference between indoor and outdoor climates, what's predicted from thermal suitability in indoor and outdoor climates. And so another thing to take away is that microclimate differences between indoor and outdoor environments could potentially have implications for different aspects of the mosquito life cycle, because they sample both of these environments throughout their lives. So it might be something to consider in downstream models. And then so the key conclusions from this preliminary work is indoor and outdoor microclimates are different, which results in different implications for predicting environmental suitability for malaria transmission. The highest vectorial capacity is associated with environments and times of season, with cooler temperatures that are closer to the thermal optimum for Plasmodium falciparum and dengue virus transmission. Oh, goodness. The spatial patterns of high vectorial capacity shift seasonally and with land use. So that suggests that our interventions might also need to consider these shifts. And then future extensions of the work include incorporating the effects of other key environmental variables, so moving from just temperature suitability to temperature and relative humidity suitability. We're also doing household surveys in these cities to try to get at some of those social aspects of risk, like water storage practices, education, interventions, access to public health care, so that we can not layer in the socioeconomic implications of exposure with our data on environmental suitability to actually get us at making risk maps across these cities. And I'm going to skip through this because of the sake of time. We're also going to be validating these models with the entomological and epidemiological data that our local government partners are collecting in these cities. And then we're hoping to write another NIH R01 after the winter holidays, where we're going to try to expand this work in the dengue system. Indian cities are nearing malaria elimination, but dengue is an expanding problem. Okay, acknowledgements. Okay, and then I would really like just to emphasize that we're hoping to use these models to forecast transmission seasonally and spatially, so that we can target our surveillance and control to times of season where we're going to potentially have the biggest effect into populations that are most at risk. And we're also hoping to use these models to look forward into the future, to consider other urbanization scenarios, as well as how mosquito-borne disease in India is going to respond to climate change in heat extreme events, et cetera. And so these are all of my collaborators. I need to thank my funding sources, including NIAID, which is funding this research. And then I have to give a big shout out to the people who are actually collecting the data on the ground, from the local municipal corporations to the insect collectors from the Ahmedabad and Surat Municipal Corporation. So thank you.
Thank you very much for this presentation and keeping to time. And we are open to questions now. So please come down and then address your questions to the person who you wish to answer.
Hello. Great presentations. I have a question for Gabriel and one for Courtney. Gabriel, as you see these diseases maybe going down into new areas, is anybody looking into potentially the vectors that are coming in with climate change, but the current mosquitoes and potential new vectors that are there and their potential vectorial capacity?
Yeah, thank you. Thank you for the question. So, yeah, in fact, we do have an entomological surveillance system in Brazil as well, and we already detected the spread of Aedes aegypti to the south. It invaded all the municipalities in South Brazil. We also have the presence of Aedes albopictus, but there is a current almost a lack of entomological studies in terms of vector competence, both for the population of those species in the south, but also for other indigenous species circulating in the region. So that's one of the things I'm trying to stimulate more, to see the role of those other species and even the role of Aedes albopictus in the transmission in this region.
All right, thank you. And Courtney, as you develop these models to understand then how the pathogen develops in the vector, can you look into the future to see how these can be applied to see if an intervention is going to work? We're developing now transmission blocking antibodies that goes into the mosquito, or drugs that penetrate the cuticle and go and kill the parasite. So how does the temperature changes and humidity will affect the efficacy of these interventions?
Can everybody hear me? Okay. No, I think that's a good point. So I definitely think that we need to expand our investigation on some of the novel vector control and novel therapeutics that are coming up in terms of how environmental variation can influence their efficacy. Things that I've worked on that kind of translate into what you're asking about would be, for example, Wolbachia, and maybe some of the other genetic modifications that rely on mosquito gene expression or the expression of other products. Those things are all going to be affected by temperature. So the relationship between Wolbachia and the mosquito, some strains are less temperature sensitive, some strains are more temperature sensitive. And then also gene expression is wildly affected by temperature. I imagine also potentially relative humidity as well. I haven't done that, we haven't done that work yet. But so that would suggest that these novel vector control interventions could vary, their efficacy could vary seasonally and could also vary geographically. And so I think that's the next important step.
Hello. Yeah. Hi. Thank you for all the presentation. So my question is for Courtney. I'm Rodrigo Corder from University of São Paulo. So your models, you're suggesting that if you change temperature and relative humidity and many other factors, you are changing the vectorial capacity and parameters from the life cycle of the mosquitoes. I'm curious to know if you used a single strain to test this, and if you have strains from different environmental places, for example, with a place with higher temperature or lower humidity, if you are expecting this to change, and then like extrapolating these predictions to the whole world or to places where malaria is transmitted, if like conclusions about shrinking malaria or this kind of conclusions, if you expect to change if you have different strains in your simulation?
No, that's an excellent question and something I think quite a lot about. For the current work, we're working with one strain of Anopheles stevensii. India has strict export prohibitions on exporting biomaterial. So we're working with a long-standing colony of Anopheles stevensii. I tried in my other studies to work with field-derived colonies. However, the Indian PIs from NIMR that I am working with will be validating what we're doing with local strains of Anopheles stevensii and local strains of Falciparum bivax. So I think it'll be interesting to see how what we're doing compares with, and it will answer part of your question. And in terms of the other part of your question, I do think that mosquitoes that live in different areas of the world, there will be local adaptation to local environments. And that's important to consider. And our models are only just beginning to think about how to build the potential for evolution in, especially with climate change. There hasn't been as much work, there's only been some work done in mosquitoes looking at the effects of local adaptation, but there's been a lot of work done in other systems like Drosophila. And they do show that, Drosophila populations from different areas of the world have different responses to both temperature and relative humidity. And that's important to consider in the context, especially of climate change and how those populations are going to respond. So, but I mean, we're still early days in mosquitoes in terms of starting to consider those effects.
Thank you very much.
Hi, Kevin Teta, Foundation for Innovative Diagnostics. First question's to Gabrielle. It's really trying to get an understanding whether the data that you're collating so far gives you any indication of how non-communicable diseases are impacting on the sort of the severity of diseases that you're measuring. And also on top of that, whether you're seeing any impact from co-infections. I think you touched on that a little bit, not just within dengue, but with out of dengue as well, and how that impacts on the data that you're seeing.
Thank you for your question. So regarding dengue and more severe disease, if I understood correctly, right? So I think we are still in early days to understand it, because overall in Brazil we do have different systems to input the information of every patient, symptomatic patients. And then now we are generating the genomic data from the same patients, right? But all the surveillance system, human surveillance system, is based on symptomatic cases, that people that seek for the health facilities. So we do not have the symptomatic ones to be able to compare and really tease apart if there is a specific serotype or a specific genotype that is leading to more symptomatic and more severe cases. There is another problem that usually the public health system do not collect or collect very heterogeneously the information about the symptoms. So most of the samples we do end up sequencing the virus genome. We do not have the associated information about the symptoms, and there is no follow-up if this patient progressed to more a severe case in a later point in time. So I think that's those are two problems that we face overall in Brazil. The data collection and data linkage between different systems. In the south of Brazil particularly, there is a bigger problem. Because of this historically it was not impacted by dengue, there is a lack of awareness completely. The entomological surveillance started later on compared to other Brazilian states. Human surveillance also started later on compared with other Brazilian states. And there is a lack of general population awareness about the importance of dengue, and also regarding the physicians. So there is a clear pattern where the physicians are not really noticing the alarming signs of dengue, and then it's one of the factors that's leading mainly this year to a higher lethality in that state, in the southernmost state of Brazil, compared to other states. So it's really a systematic problem that we need to address, and we have to deploy our tools to try to mitigate dengue in this region. So that was the first question, but the second...
the second question, which was for Courtney, is that right? Yeah. So the second question really was, it's probably a bit early days, but to really understand how your modeling can interact and influence the diagnostic sort of picture. So one of the things we're really driving is really trying to understand how we can support health system strengthening and really target diagnostics to the place that are needed the most. And so I got, from what you were saying, it sounds like that sort of detection of hotspots of vector transmission might be quite a powerful tool to incorporate to things like universal healthcare coverage and the such.
Yeah, no, that's exactly where we like to go. It's early days because we haven't built the models yet, but I think, so for some of the field work that I've done in India, I think the models will be useful, mainly because there are definitely some that I know hotspots that if we can target, for example, in the pre-monsoon season, we might have a big effect moving into the monsoon season when mosquito-borne diseases start expanding. So these can include areas that are of lower socioeconomic standing, but also construction sites. So construction sites are these amazing refugia for mosquito-borne disease, especially in hostile climate times like the pre-monsoon season. There's water. It's like an urban cave. Mosquitoes love to, hang out there and rest there. And then we have migrants that come in from the rural areas, and they sleep in these buildings as they're being constructed. They're also outside of the surveillance program of the cities because they're not citizens of the city. So it's a perfect storm. But I think if you can hit construction sites, for example, very hard in the pre-monsoon season, you may have a bigger effect as mosquitoes start spreading out from those construction sites, to the neighborhoods surrounding them, moving into the monsoon season.
Okay. All right. Thank you.
My question goes first for Dr. Gabriel, because I heard what you said about the influence of climate change in the resurgence of new strains of virus, and I was wondering if you thought about the influence of herd immunity in the resurgence of these new strains, and what about you think this? Because we know that this is a factor that can improve or you can, how can I say, you can you have the big resurgence of new strains because of this.
Mm-hmm. Thank you for the question. So regarding, I will start for the last one. Regarding herd immunity, so I think in Brazil, in south of Brazil, we have almost a lack of herd immunity because historically it was not impacted by dengue virus. So that's why we have a almost completely naive population, and doesn't matter the lineage or the serotype that arrived there. And we are not seeing any new lineage emerging. Those are the lineages that were circulating in the tropical part of Brazil that are circulating there, and they are causing huge outbreaks. So it looks like we do have highly competent vectors. The Egyptian population, they adapted to this mild winter time in the south of Brazil. They are able to transmit the virus very effectively. And because the population have no herd immunity, then any kind of lineage will spread fast and cause large outbreaks. Another thing I'd like to mention linked to that is that I didn't have time to show you all the pieces of information we have, but there are some studies showing that in south of Brazil now we do have a larger transmission season. So what's happening is not higher temperature. In fact, linked to Dr. Murdock's talk, we are seeing more months where the temperature are ranging between 16 and 32 degrees, where we have the perfect range of viral replication inside of the mosquito vector and transmission to new patients. So we are clearly see this. We still have winter, but very few weeks of cold winter. Now we have more enlarged. It's already increased 1 month and supposed to increase more 2 or 3 months in the next decades of this larger transmission season, where we do have the perfect temperature for increased transmission regarding the vector and viral pathogen coevolution.
Okay, thank you.
Thank you.
And my other question goes to Dr. Courtney, because I was wondering if you thought about doing metabolomics or proteomics of these mosquitoes to see if they have some differences, and so you can find a target to combat these mosquitoes.
Yeah, so we've actually started doing some of the work, but we've started with the transcriptomics. So we're currently in the process of writing this work up. So if you look at for example, and it's been in the context of temperature. So if you look at, the impact of temperature on the proportion of mosquitoes that become infectious, it's this symmetrical relationship. However, if you look at how it affects parasite development rate, it kind of goes up and just starts rolling over. But what's really constraining the efficiency of infection is mosquito mortality. So with increasing temperature, the mosquito efficiency of infection, just the parasite development rate just continues to go up. So what that suggests is what's constraining transmission on the cool end versus the warm end, the mechanisms might be different. So in the warm end, the parasite's just not doing very well. It's not establishing. It's not generating